Patient management. Let's do this one. Who wants to take this one? It's an easy one. Should be. To describe. Who wants to
I can do it if no one else is going to volunteer, but I've already been, so I'm happy to wait for other people to volunteer.
I'll go for it. We're running out of time. Go for it.
Okay. So this is a fundus photograph patient. You can see the most obvious abnormality is a left leukocoria. So it is a VIVA station. So is this me just talking about causes? So causes.
Yeah. So what's the sort of likely diagnosis and then also the other causes?
So cause of leukocoria can include a retinoblastoma, a congenital cataract. This child looks a bit older than congenital, might be also an acquired cataract. Persistent fetal vasculature, Coats disease, retinal detachment, or any other sort of posterior segment lesion. So in rare cases like a toxicalis.
And in that case, what do you think the diagnosis is?
So this looks like a congenital cataract, possibly.
Fine. Okay. Or acquired, we don't know. Fine.
Yeah.
There's no history. What other sign is there which is very important?
They've got a slight esotropia of the left eye.
Yes. Why is that relevant?
Because that means there might be there's a risk of amblyopia, so that might be a sensory esotropia.
Yes. So there is a few sort of risky indications where, you know, it would be sort of pushing you towards sort of more urgent sort of management. So esotropia is one thing, vision, obviously, and then the clarity of the fundus. So again, there's some sort of grading somewhere that, you know, if you can see the fundus well, then, you know, it's not that significant. If you see it blurry with the direct, then it's more concerning. If you can't see it with the indirect, then it's very sort of urgent. Why do you think it's relevant if it's one eye or both eyes?
So you want to investigate. So if a unilateral cataract is most likely can be sporadic or AD, but it's unlikely to be associated with other systemic conditions. So where in the case of a bilateral cataract, you'd be more concerned about a syndromic or systemic association. So you'd want to do more of a workup in the absence of any other cause.
Fine. Do you know any other systemic causes for it? I mean,
so galactosemia. So that's where you do urine and urine analysis. It can be so like as in a bilateral cataract or unilateral cataract. So you can get,
let's say, bilateral. Yeah, other causes.
So Down
more
syndrome,
common actually.
And more likely to have Down syndrome, and more likely to have congenital.
Fine. Okay.
Any metabolic conditions. So as a galactosemia, alpha. There's also Fabry disease also give you possibly cataract as well.
And low syndrome.
Yeah.
So besides hereditary sort of genetic stuff, any other sort of causes more important?
For a bilateral cataract?
Yeah. Maybe not in the UK, but outside the UK.
So like infectious causes?
Infectious. What's the mnemonic for them? Do you know?
Torch infection.
So tell us more about torch. What are those?
Toxoplasmosis, other infections such as herpes, rubella, CMV, and I mean, I thought the H was herpes virus.
I think it's herpes.
Yeah. So torch infections, that'd be part of your screening for bilateral cataract workup.
Fine. Especially outside the UK, you know, these infections can cause this thing. Fine. Okay. And the other significance of unilateral versus bilateral is actually the urgency as well. So a unilateral cataract is a very amblyogenic thing.
Yeah.
Okay. So it's more urgent to actually do something about it. Okay. Obviously, it depends on the history, but one eye problem in a child is very bad. Okay, if it's bilateral and symmetrical, then it's less urgent. But it's one eye, then you need to do something about it very quick. Fine. The other question might be vision testing. So let's say if this was a 6-month child, how would you assess their vision?
So 6-month children should be able, from 3 months anyway, to fix and follow. So that might be it. It might also be they might resist occlusion of one eye. They also, I don't think they're old enough yet to be doing cardiac acuity cards, but that might be the next step up from fixing and following.
Yeah. So fixing and following is CSM. Yeah. So central, steady, maintained.
Okay.
Yeah. Tell me more about any sort of clues on their visual sort of, potential. I mean, any other signs you can do? How would you assess vision in children?
So we've done their visual acuity. We've checked they've got a slight esotropia here. So you've done ocular motility to look for any amblyopia possible amblyopia. You could do, if you're not sure, and you could do a B scan to make sure the back of the eye is intact, and you could do electrodiagnostic tests if you wanted for the patient to confirm it's amblyopia, or if there's any optic nerve dysfunction or any other problems contributing. Examine the other eye, take a family history. You could do an EUA if the patient's very difficult to examine in clinic.
Yep.
And then if you do find a refractive error, you can correct it and see if that improves their vision.
Fine. Okay. Fine. EUA is very important.
Yeah.
What else will I say? I forgot now. RAPD, did you mention RAPD?
I didn't, but yeah, that's so. An RAPD would be a significant because it would show optic nerve dysfunction. So even if they haven't got a fundal view and you've got cataract, if you've got optic nerve dysfunction, then you're going to have an RAPD.
Fine. And again, you mentioned family history, so again, examine the parents, sometimes examine the siblings as well. Investigations, you mentioned B scans. It says unilateral, no tests required. Anyway, bilateral, we discussed bilateral, the systemic associations, treatment options. So
yeah,
tell me what treatments are available. What would you do? How would you manage?
So it's the unilateral cataract. So I think the guidance says that you should try and do surgical correction within 6 weeks. And then for bilateral, I think it's 10 weeks. So in this case, you've got a choice as to whether you leave the patient aphakic or put in an IOL. So if they're aphakic, which I think is often the preference for most pediatric ophthalmologists that I work with.
Why is that?
So it's because when firstly, biometry is going to be difficult, and secondly, the eye is going to change so much in shape and size. They're at a very, very rapid period of growth. So you're then going to have an inaccurate IOL, and that's probably going to be more amblyogenic than if you leave them aphakic and correct them with a contact lens.
Yes. And we discussed this earlier. So what happens in children after their surgery? The commonest sort of complication that happens?
They're very prone to inflammation. They have a very strong inflammatory response. So if they're left aphakic, they are more likely to develop aphakic glaucoma.
Glaucoma, yes. So obviously you need to keep a close watch on them. Hit them hard with steroids, very, very hard. Sometimes even oral steroids and those sorts of things. It depends on the age, obviously, but hit them hard. You mentioned aphakic. So, and if you leave them aphakic, so how would you correct their refractive error?
You can correct them with a contact lens if they can tolerate it and the parents are happy to manage that contact lens, knowing the risks of, microbial keratitis and sliding and abrasions. Or you could do spectacle correction, but again, that's quite tricky with a child. So one of the two. And
what's the issue with unilateral aphakia with glasses?
So you'd worry a bit about the balance. So they can have jumping, and if it's very high power in the lens, then they're going to have quite a big difference in their prescription between the two eyes. So if the one eye is normal, then they're going to worry about jumping because they're going to have to correct that lens very hard. And so all the prismatic effects of having a very strong lens and a basically zero lens. And
anisoconia, obviously, so there's a big difference in the size, so they will get double vision basically, and that can cause amblyopia itself. So usually glasses just don't work. They don't work basically. So usually it's contact lenses. The fact that you leave them aphakic, as you said, so their eye changes with time. So actually, if you put a lens and you make them emmetropic, they say that you should leave them a bit hyperopic. So that's the normal development of this. So they emmetropize with time. So the eye elongates. This is sort of an urge for the eye to actually elongate if the image falls behind the eye. So if you put them at emmetropia, the eye might not grow normally as the other eye. So that is the reason why you sometimes just wait and then you put the lens as a secondary sort of IOL later on. Fine, we discussed the lenses, we discussed the spectacles. Obviously, if the risk of amblyopia, how would you manage the amblyopia?
So if they're becoming amblyopic, so I'd be monitoring them regularly and doing their visual acuity, blah, blah, blah. And if I notice that they're having a slide in one eye, so the vision's becoming worse, they're becoming amblyopic, then I consider a trial of patching, or you could do atropine penalization. But I think generally most pediatric ophthalmologists in the UK go for patching, and you can patch them. So you can start, it's very difficult for children because they don't tolerate patches very well because they're looking at their bad eye and they want to tear the other patch off of their good eye. So you reassure the parents that you can start at 15 minutes, but ideally you want to do about an hour per day per age of the patient.
Fine. You know of the study, the
PDIG study.
yeah, so they compared 6 hours versus 2 hours, and then I think they compared the atropine to patching.
Yeah.
It would be a bit mean to go into those studies, but they can show up in the evidence-based medicine.
So they found, isn't it, that 2 hours was equivalent to 6 hours, and that atropinization was actually very good,
Yeah.
and actually equivalent to patching.
Yeah. So if you want to sort of save your time, you just say I'm going to patch them 2 hours per day. Yeah,
Yeah.
depends on the
Okay.
sort of compliance and so on. So and depends on the vision as well, actually. But the standard sort of thing, just 2 hours. Yeah, if they
Yeah.
can do 2 hours, and obviously correcting their refractive error as we discussed. I think we've covered most stuff. I don't think they're going to go into any details about the surgery itself because, again, unlike adult phacos, we're not pediatric phaco surgeons. So, but very, very quickly, again, there is a few sort of changes with pediatric surgeries. Is that first of all, obviously, it had to be a GA. Obviously, you need to suture afterwards. You have to do a posterior capsulotomy, usually an anterior vitrectomy. It's quite a very soft cataract, so you don't need to use phaco at all. It's usually aspirated. Yeah, maybe inject them with lots of steroids afterwards, so subconscious dex or something for the steroid response, for the inflammatory response. Those sort of adjustments and put sutures as we discussed at the end. But I don't think they will go into any surgical detail about cataract surgery.
Okay, thank you.
Well done, well done. Fine.